I'm just kidding. I'm just kidding. Is that better? Are you good? Okay. Oh, okay. There you go. All right. So I'm going to cover not only what some of the top standards are. I'm not going to spend a ton of time on that because pretty much any conference you go to, that's what they're going to talk about is what the top findings are. I'll cover what you need to know, at least out of the top 10 right now. We're going to talk a little bit about some things in the SOC. We're going to focus quite a bit on standards language changes that went into effect last year for utilities equipment. And then we're going to talk a little bit about the extension and equivalency process. Please feel free to stop me if you have questions while I'm speaking. I would really much rather take your question while the slide sets up and when you have it. We don't really need to hold for formal Q&A. Just feel free to stop me as I go and ask me any questions that you may have. So I'm going to go over the top 10, which luckily, I'm not really sure. 8 of the top 10 belong to us in the environment of care and life safety arena. None of this actually should be shocking to you. These standards have been the same for a number of years, all 5 at least that I have been there. It's which order and where they fall into the order, I think, changes over the years. I think which elements of performance get scored and which ones become the key areas for compliance also kind of change as we see some of these scores jump. It's a little surprising to me that we had such a significant jump in the very first score, EC 261. This is safe patient care environment. And you can see we went from 39% in 2013 up to 56%. A couple reasons for that. Safe patient care environment is not just things that the life safety code surveyor is going to look at, but your clinical surveyors are also out in the environment while they're doing their patient tracers. They pull those files, they trace the patient throughout the building. They're coming across things that they are going to identify as risks in the environment. So you're going to see a number of scores, I think, at this particular standard and the elements of performance attached that may come from the clinical surveyor's perspective. Particular EPs that are scored here, probably the 2 most popular are EP number 1 for the built environment itself. Any of you providing care for behavioral type settings or behavioral type areas, behavioral risks in the environment has become a really hot topic of late. Not only are our surveyors looking at it, but a number of the CMS surveyors are looking at it. It has become a kind of a focus area, I think at least we've seen trending. So, exposed plumbing, hinges, right? All of those little parts and pieces and components that you see. Now, it is understood that these aren't just quick fixes. We can't always just turn screws, right? Or we can't just go and buy a part. A lot of these things have to be fabricated. The question becomes, what have you done on the clinical side to mitigate those risks in the physical environment until you can get those actual corrective actions in place? We want to see the connection between the clinical team providing clinical care and the facilities team maintaining that environment in which patient care is being delivered. So that's going to be a key piece, especially to the clinical surveyors that are in there and are tracing through their processes and their patient tracers. Where is that clinical connection? We've seen a risk. Is there a clinical mitigator on the other side? What's the screening process look like? What is the staffing levels? What are they doing to mitigate those? EP 13 would be the other EP that I see scored here very frequently, and that's for maintaining temperature and humidity. What is your maintenance strategy for maintaining temperature and humidity in areas where there are critical temperatures and humidities that are required to be maintained? Where are you going to find that information? Of course, the design guidelines, ASHRAE table. It's going to tell you where we are expecting humidity levels to be maintained. Is your building automation system monitoring it? Are we putting that requirement onto frontline staff? I have to tell you, I've been surveying a little bit lately, and I can't tell you how aggravating it is to go into a clinical area and have a clinician say, yep, I track humidity. I do it every day. The facilities guys made me this really nice 3-ring binder. It's got all these sheets in it. You can take a look at it. We sign off on it, right? Go in and we open the book, I take a look, and she's right. The chart's all filled out, somebody's initials are all signatured, but like 5 out of 7 days, we've got non-compliance. Nobody bothered to call you guys. How can I ask you to fix an issue in the environment if the clinical team doesn't connect it back to you, right? I'd like to try to focus on closing that communication loop between what our clinicians are doing and what you guys are doing. There's only so much I can ask you to do, right, to fix it unless you know about it. And if you don't know about it, how can I really expect you to fix it? So that communication piece, I think, is key. It's also something that we are seeing scored out here. The second score, EC 251, this pertains to utilities equipment. Probably still the number one element of performance that's scored here. is now EP15. We used to call it EP6 before we made the changes we're going to talk about in a little bit. And I can't understand why on earth we're still talking about this, but this is appropriate pressure differentials. If any of you have ever seen me speak over the last couple of years, you'll know that I'm the proud mother of twins who forced me into my very first surgery ever. I had to go into the OR and have a C-section. I was not happy about it. Kicking and screaming on the gurney, not wanting to go, right? Because I wanted to do this the right way. And after my fight with the clinical staff where they said it's time to get her drugged up and get her in that room, let's go, we got to the opening doors, the doors for the operating room, and I screamed stop at the top of my lungs. And of course the clinicians are like, what's the matter with you? What's wrong? And I said, which way are those doors blowing? And she said, excuse me? I said, which way are those doors blowing? She said, lady, we're having babies. We're not talking about doors. What is wrong with you? I said, I am not going in that room until you tell me which way those doors are blowing. And of course, that's when they were trying to push more drugs faster, right? Knock her out, get her out, right? But I would not let her anywhere near that room. I was not going to go until I had my hand on that door and I could feel that positive pressure. Now, why is that? Of course, the ORs have to be positively pressured. How crazy is it that some woman at 38 weeks with twins ready to go is not wanting to go because she wants to know what the conditions of the room are? I knew to ask the question. Can you imagine the poor people that don't know to ask the question? Every day when I do report review across my desk, I have negative ORs. I have reports, and these aren't just little teeny tiny hospitals, major teaching hospitals, major hospitals across country, moderate-sized hospitals across the country. Improper pressure differentials happen, and they're still happening. They've been happening. My twins are 3.5 now, by the way. So I've been telling this story for a whole lot of years now, and I'm still seeing it cross my desk. We went from 47% in 2013 back up to 53%. We've been on the rise with this year after year after year. I also had surgery this past March in an ambulatory surgery center, which was a nice twist out of the hospital setting into the HC environment. And I was in a brand new building. Poor facilities guy, same facilities guy. Pretty sure he doesn't want to be my friend anymore. I went to the outpatient center, got my pre-op. She puts me in the wheelchair. I'm getting ready to go, wheeling down. And as we are approaching these rooms, brand new, open 3 months, just gorgeous, shiny, sparkly, new, right? Had that new building smell to it. And I said to the nurse, is that the room we're going to? She says, yeah. I said, would you mind if I put my hand on the door before we go into the room? And she said, ooh, is that like some superstition thing? I haven't heard this one. Tell me all about it. And I said, well, it's kind of superstitious. She said, no, seriously, what do you want to know for? And then, of course, I tell her I'm looking for pressure differentials. And she goes, you're one of them engineer people, aren't you? And I said, yeah, that's me. I know to ask. Now, of course, when we got in the room, which was properly pressurized, they put me up on the table. And now I'm looking around, right? And I'm all distracted because I've got shiny new things that I'm looking for. And I'm scoping out the medical equipment on the wall, right? I'm trying to see what I see. And so the tech walks up and he says, hey, lady, what you looking at? I said, I'm looking for stickers. He said, stickers? I said, yeah, you know, like on all of this stuff. He goes, you know, we use stickers. I'm not sure where it is on this. I said, really? You don't know where it is on this? And of course, here comes the anesthesiologist and she goes, you're not supposed to talk to her. Let's go. I did get a phone call a week later from my facilities friend who said, I don't use stickers anymore. It's in the computer. You could have pulled it up. It was right there on the desk, and he went through his entire process for me, which I already knew going into it, which I thought was kind of funny. But again, staff training piece. Can you imagine being on a survey with a clinical surveyor or in a life safety surveyor coming through that room, taking a look at it, talking to a tech, and he says, yeah, I know we put stickers on these things. I'm not sure which ones we put stickers on or where to find them, but I know we put stickers on these things. And then you talk to the facility guy who's standing in the back going, we don't use stickers anymore, right? It's that clinical connection, clinical counterparts, biomed, all of the groups getting together and talking through the survey process. This is where we have those unusual or tight survey issues that happen, right? Nobody wants to talk about them. Who's walking around with the life safety surveyor doing a survey? You guys are, right? Who's walking around with the clinicians? Not you guys, right? So when those questions and those dialogues happen and those things come up, we need to be able to close the loop to make sure that the right person, the person who was not in the room at the time, is asked those questions and we can make those connections to go through those processes and validate that they're really in place. Does that make sense? Am I saying anything shocking to anybody? Ready to throw me out yet? Okay, good. True. It is shocking that we don't, but that's true. And I think that we're finding as we go through the survey process that the clinical facilities communication piece isn't as strong as I think we hope it is. And I'd really like to see over the next couple coming years a focus on just those discussion points, the ability to talk through some of those policies and procedures, knowing why we do what we do, not just that you have to do this. Here's a policy, just do it. Put that oxygen cylinder in this rack. Just make sure you do that, okay? Well, why are we doing that? So that when I can't do that and you're not around to tell me, maybe I can make those connections, or I pick up the phone and I call the right person. Make sense? You'll see number 4, felon life safety. I've got a 2% drop here. I'm pretty happy about that 2% drop. I know it's only 2%, but heck, I'll take a drop anywhere I can get it. 2120 happens to be maintenance of the means of egress. All things related to exiting, exit strategies, requirements for the means of egress. I can't tell you exactly why there's a 2%. You're going to notice a trend here when I get to my next couple of LSs where I'm losing some percentage points. I have some ideas. You can tell me?
Because if any goes over, they're not looking at that.
Oh, okay. Okay, I don't have numbers to back that play, but we'll pretend for a while. You'll notice here at number 6, Environment of Care, EC235, got a 3% jump here. EC235 is fire protection systems testing. We are still running into issues with documentation. A few years ago, we were having trouble with systems not being tested. And I will tell you that there are still surveys where we find stuff that got missed or stuff that didn't get tested. But for the most part, I would tell you that the strong driver of these percentages is incomplete or inaccurate documentation. We still do not have effective inventories of our systems. Yes, sir.
Can you speak to after-hours testing and physical pulling of alarms versus just announced drills, so there's silent, so to speak, silent drills?
So you want me to speak specifically to fire drills or testing of the equipment?
Is it a requirement to activate the alarm system in the after-hour drills?
Okay. Is it a requirement to activate your fire alarm system in an after-hours drill, which I'm assuming you mean 9 p.m. to 6 a.m.? In the Life Safety Code, the Life Safety Code says that if you're going to do a fire drill between the hours of 9 p.m. and 6 a.m., you may silence your audibles. That is a permission. The code will allow you to silence the audibles. Nowhere in that section of the code will it tell you that you don't have to activate your fire alarm system. The base requirement of the code is that you will activate that fire alarm system. If you don't want to disrupt patient care, which obviously is a key point here, it will allow you to silence those audibles. There is also no allowance in that section of the code to allow you to silence, to eliminate strobes. So if you have strobes, the visual, easy for me to say, visual notification is not exempt in that code section either, just the audible alarms. Okay?
And you said from 6 to what?
9 p.m. to 6 a.m., the overnight shift for sleeping hours, yep. And that's just the base language right out of the 2000 edition Life Safety Code.
So even on panels, you can't silence?
You can silence the audibles, sure.
Well, not all panels have that choice where you can have the activation and still silence your alarm.
And while I have heard that, we have reached out to NFPA, and there is no designation or allowance within the body of the code. The language only addresses your ability to silence the audibles. And it's a permission, it's not a requirement. Granted, the permission obviously serves to better patient care. You don't want the alarms going off, ringing all those audibles at 3 a.m. and disrupting patient care. But I'm also working off of a 15-year-old code. So there are some challenges, obviously, that are tied to working off of the old code language and some of the technological advances that have been made over time. Okay? So for EC235, fire protection systems testing, I think inventory is a big key piece. I would ask the question, if you're relying on your vendors to provide you a device inventory, why are you doing that? Shouldn't you have your own device inventory to know exactly how many devices your vendors should be testing for you? If you're relying on the vendor to tell you you have 300 smoke detectors, you're simply trusting that their count was accurate and correct. But they don't live there, you do. So you should know that you really have 357 and not really 300. It's great that the report says 300 devices tested. That's not a problem. The problem is how many are really inside the building. We are still seeing documentation that shows all with a checkbox, all strobes, all pull stations, all duct detectors. We're still seeing all notification, so a lot of that is encompassed here at 235 and the 3% jump you'll see here. Life safety, 2110. This is general requirements, our fire barriers, our fire doors, managing penetrations in our 1 hour and 2 hour rated walls, right? The functionality. Is there a good program in place to manage those barriers? Again, I've got a 2% drop here, down from 48 to 46. I'll take it. I'll take the 2% where I can get it. Number 8, LS2130 covers things like our smoke barriers. Again, issues with barrier management, penetrations, functioning doors, hazardous areas. Are we converting hazardous areas and protecting them appropriately? Are we protecting the existing hazardous areas appropriately? Does anybody ever play around with the doors? Anybody tape the latches, shove stuff up into your closures, right? That stuff never happens. We never see that in the environment, no. No. But you will see I've got a 2% drop here. Now I will tell you that looking at 2120, 2110, 2130, I would like to think that the 2% drop could be attributed to the education that we focused over the last year and a half through the Barrier Management Symposium. We were out here in Long Beach last year for the California area to do the Barrier Management Symposium. We only have, I think, 3 or 4 more chapters left. So we've been all over the country. We're rounding out that program. We've been really well received with it. All of those slide sets are still online. They're still available. So if you weren't able to make it last year, or if you came and you weren't able to bring your staff, know that you can get those parts and pieces, and they're broken down by presenter. So it's not like it's just a day and a half, 12 hours worth of content that you have to sit and pay attention to. You can break it up into hour segments. That's something that you can provide training to your frontline staff on. Might be a resource for you. You can get those off the FCIA website. I think it's fcia.org. Number 9, you'll see here is LS2135. This is issues relating to the sprinkler system. Again, I've got a pretty significant jump, 7% over the year. Things like the 18-inch rule, as they call it, maintaining appropriate storage levels 18 inches below the sprinkler deflector. You tape a line on the wall, right? We give a visual cue. We go through and we do rounding. How much more can I ask you from an implementation perspective to do in those spaces? You've taped the walls. We've provided some education, right? How much more can we do? This is one of those areas where at some point, I can't say that there's anything more I can ask facilities to implement. This is going to come back down to that staff communication, looking at what staff is doing in the field, monitoring those activities during your rounding efforts, seeing which areas are being successful and which areas are not, and going back to looking at our staff training and explanation of why we're doing what we're doing and where those code requirements tie in.
Does that include the foreign particles over the sprinklers too?
Yeah, like dirty sprinkler heads.
Right.
That is scored under that particular standard as well. Clinicians.
And that is, I think that's what the increase is. That's what we're seeing with clinicians.
Clinicians tying into what the sprinkler system conditions. That's not one of the EPs that rises to the top. I will tell you, I do see that scored out in survey reports. I'd like to know that you have some kind of activity for maintenance on those. We're not going to dictate what that is. FA 25 is going to talk to you about some of the strategies that you're going to need for maintaining the sprinkler system. There isn't an EP tied to having an actual maintenance activity for the heads, but yeah, I know it's kind of subject to what they see.
180 PSI.
Yep. Nope, I completely agree with you. And when we talk to the surveyors, when we go through those training modules, what we're looking for really are those areas, like the kitchen where we have, high grease buildup, or the opportunity really for film and things that are going to coat the bulb that's going to affect the temperature rise and the sprinkler activation and that sort of thing. I know that's not what the surveyors are seeing. Again, if you do environmental rounds, and that is something that you look at on environmental rounds, you may be able to go through the audit process during clarification. Might be something that's eligible to audit data throughout the process. And then at number 10, EC221, this is hazardous materials, just a 2% increase here. Over the last couple of years, we've really kind of hammered eye wash stations to death, I think. So I'm hoping that some of the dust is settling around that, because of course you all want to go home tomorrow and install 50 more of them, right? You think you don't have enough of them? Just let's put some more in, right? Of course not. I'd like you to go home and actually assess the ones you have. I'd like you to find out why you've got what you've got, and do you need to maintain any of the ones that you still have? Of course, if you do still have a need or a risk for those, then yes, those are going to be ones you're going to maintain. I'd also tell you that a couple of the things we're seeing scored out here, and kind of where the trend is going, where I think the 2% is, we're providing PPE. We're doing a good job of taking a look at where we need PPE and what we need. And then when we get into the field and we're doing the surveys, we're actually seeing staff not using it. Go into a clinical lab area, for example, and nobody's using PPE. There's a big push on the clinical side for infection control. We're seeing a lot of issues today with sterilization and infection control being inappropriate. This is also another time where they'll be able to assess appropriate use of PPE and whether or not staff is using PPE appropriately. So again, if you're doing rounding, you're doing staff training and education, you might want to look at when staff are using it, when they're not using it, what are the barricades to them using it, why are they not using it when they're supposed to, because that's something else that's another big score at 221. We had a big wave of hot lab escort questions come up, some scoring on the hot lab. Hot labs are surveyed to your policy. We do not tell you how to do that. That is not prescriptive in the standards. So it's important to know what's in your policy. It's important that staff knows what's in your policy. And again, the answers that are given about hot lab escorts are tied back to what your policy and what your actual procedures are. Anybody have any questions on the top 8?
3 to 2%, that EC02001 is related to what's Iowa stations run?
EP5, sure, eyewash stations would fall in there. The PPE would fall in there. Hot lab, hazardous gases and vapors.
That's the other thing.
Manifests, too. The clinical piece for hazardous gases and vapors.
No, for the locational Iowa stations.
Eyewash station, sure. Now, again, that's going to be a question that's going to come back up. If a surveyor sees the eyewash station installed, obviously it must be maintained in accordance with that installation. If you are having a surveyor ask you why an eyewash is not installed in a certain location, of course the answer back would be that there are no caustic or corrosive chemicals in use or that fall in accordance with the ANSI standard to require it. That should be a simple discussion point during the survey.
With the life safety code or advanced, it's a simple discussion, but not with the clinical survey. That's one of the things.
It's not even simple with the life safety surveyors because they're looking at the containers. It may not be a corrosive, but they're seeing 15-minute
Flush.
flushing, and they're saying, well, then we have to have an eyewash.
Sure, I'm sorry. There was some discussion about EC221 and EP5 and whether or not eyewash stations were scored there. When are they required? When are they not required? And what are some survey experience? Clinical surveyors surveying them. I didn't mean to cut you off. I apologize. The gentleman said that it's also the life safety code surveyors, so thank you very much, that are also tagging into it based on materials. And I will tell you that we do train the surveyors, and we have told the surveyors that just because the bottle says 15-minute flush does not mean a plumbed eyewash station is required. The ANSI standard only requires it to be installed where there's a caustic or corrosive material in use within the, with the space or the area within the appropriate travel distance. So I think that the answer to the surveyor back, whether it's a clinical surveyor or it's a life safety surveyor, should be where they're saying you need this here because I see a bottle in a 15-minute flush. The question is, what are your first aid measures? I'd prefer to use the term first aid that gets me through to that necessary 15-minute flush that's on the back of the bottle. At the end of the day, I don't think there's a manufacturer out there that doesn't put 15-minute flush just to be safe, right? I mean, we're in a day of legislation, right? Everybody will sue every chance they get. So there isn't a manufacturer that isn't going to give you some sort of precaution. And again, the ANSI standard simply, again, knowing that the ANSI standard requires it for caustic and corrosive, that's the key to having the successful observation either written or removed during the survey process.
Their pH value, I think that's what it says.
It's also there. Yes, ma'am.
Can you define when it's appropriate to place a shower versus an eye wash station? I've had this come up in our EOC, and it's kind of like a definition of how that.
Of a shower versus an eye wash. And I am not an OSHA expert. I will never claim to be. I would be happy to look that up for you and see if I can get you some guidance on the designator between the two. I don't know the answer to that question right off the top of my head, but I would be happy to get you a card and we could work through that answer for you. Yep, I had somebody in the back.
Yeah, I had a question. One on the eyewash. Most of what we put in, we put it in a valve to maintain water temperature.
Sure.
I don't think that's something that's actually surveyed for, just the low water. I think we get those safety.
I will tell you that I do see scores and observations in reports for eyewash stations being connected to just one or the other, hot or cold, and a lack of a mixing valve installed. So surveyors do key in on that. More times it's the life safety surveyor than the clinician, but there are some clinicians that do pick up on that.
Next question is on
Correct. In the 50-year test, it's there. You're right. And we don't have an EP for it. And I'm kind of hesitant to roll it out. You know it's there. It's a requirement. You know you got to get there. But it's not one that is, at this time, an EP tied to for the survey process. And I'm really not encouraging them to write any more EPs for you guys. I think you have enough EPs to manage. That's all right. Don't give me any more ammunition in the big picture. We have a lot of EPs to manage. It's good, you know it's there, and there are other regulatory agencies that will look for that documentation and look to have you get there. But just right now, that's not something I would expect my surveyor to ask for. Yes, sir.
Can we elaborate on ECO 20501?
Sure.
And EP1 and 15, how it's now conditional level finding, right?
Okay.
How did the Joint Commission come to that assumption?
Oh, that assessment.
Because I actually, I did so much research on it. I looked
Sure.
at the U.S. Medical Library and tried to find any case studies that said that
For pressure differentials?
or negative pressure, even OR,
Sure.
actually cause infection in the patient. I could not find it.
Okay.
Like the ones that come up are urinary infection, respiratory infection, surgical site infection, vascular, catheter infection, and septicemia. Those are what the ones that are driving it. So I don't understand why that's a conditional finding when there's really no studies to back it up. Most of the scientists that say it, they're like, this is a good practice. Yes, we need to do that. But
Sure.
can we?
Sure. So his question is, how did we get, when a score happens in EC at 251, the current EP15, which is the improper pressure differential in the critical areas, how did we get to an automatic condition level deficiency? And what that ties to is when CMS deems us, they give us our deemed status, they review all of our standards and our elements of performance, and the different scores are linked to the different conditions of participation. 482.42 in the hospital setting is the infection control condition of participation. That COP has been linked at that location. It's just a link and a tie through CMS's practices and their processes. The link is, it's twofold. Our EPs, we make recommendations to CMS what we want to do, and then they come back and say, no, you're going to do it this way. So while it is a two-way street, it's really them telling us what we're required to link as far as COPs are concerned, and where we have latitude to link multiple.
So in this case, was it CMS dictating this?
CMS agrees that air pressure differential issues are linked to an infection control issue. Yes.
Why? May I state the question
Sure.
a little bit differently? Was it Joint Commission's recommendation to CMS that it be linked to that condition of participation?
That I don't know. I'm not at the table for that. Those are people who get paid a lot more than me. I will tell you that the infection control issues from an HVAC system standpoint and looking at what happens in negative environments, what happens in positive environments, there is an infection control tie. There are clinical cases. Correct. And when you look at the list of critical areas, it is areas like airborne isolation infection, OR areas, SPD, places where those things can abound. So there is some, and I don't know what the formula is for it, but for connecting the conditions of participation, there was some logic and some study that went behind that for connecting those COPs. Now, good or bad, the survey process has the ability to roll that condition level deficiency down and make it standard level during the survey process. When the report stops in central office for us to review, we can also look at the situation and determine whether or not it rises to that level of criticality. So there is the flexibility in that movement, if you will, for us to be able to do that. And it happens often. When corrective actions are taken, 9 times out of 10, it gets rolled down. What we want to look at, though, I don't want to focus on the instance. I want to focus on the process. A door can get left open. Something can get propped. I mean, things that can happen that are normal daily events that can throw an air balance off. But do we have a process in place that catches that, or were you waiting for us to come and find it for you? So I think that there's more process questions that need to be asked in the big picture that really tie to whether or not that level of criticality is met. Does that make sense? And to answer your question, at 251, you're right. EP1 has a link there too. Typically, if that stops in central office, I always roll that down because design is not a driver as far as I'm concerned. But again, the system automatically triggers that, so it's up to us to manually override that. Other questions? Yes, sir.
As far as inventory of frontline systems, is it okay to
Inventory for your fire alarm system. Is Excel spreadsheets okay? Sure. You want to have somebody sit down on paper and pencil it? Be my guest. Of course, we're moving on, and many places are using more than that, but the standards don't tell you how to maintain your inventories or what they have to look like, just that you have to have them. So Excel is great. A lot of people use their building maintenance program because a lot of times they're going to generate PMs that are going to get them to those areas. So we'll accept an inventory list out of your BMP. A lot of places have fancy software that will pool all of that for them. Whatever you want to use. We're open to looking at how you've tackled the problem. Other questions?
To answer your question regarding why are we dependent on the vendors to do that, and the reason is that most of them provide logistics, and to pull that inventory from their software, it requires the vendors. And that's why we're dependent on our vendors to do it.
And I understand the systems and the reporting. I get that piece of it, but I also think that it's in your best interest as the owner to also have that piece tied to it too. I think it serves you best in the end. Other questions? No? Okay. You guys have access to all these slides. I thought this was interesting when we pulled this data together, talking about the risks with utility systems and improper pressure differentials as being, one of the hot topics that everybody's looking for. Back in 2011, it scored out at number 13, really low on the list, things we weren't catching. So the question is, how many years do we go and find, or not find, I should say, all of these areas that had improper pressure differentials, given that this year it's the number 2 score in the big picture. Same is true with the built environment. Back in 2011, it was number 11. Didn't even hit the top 10. Today, it's the number 1 thing we're finding, areas for risk. So if you're looking for your quality people come to you and say, hey, where should we be focusing? That ICM thing is coming up, that intra-cycle monitoring. What do you think we should take a look at? This might give you some areas to take a look at from the surveyor perspective as to where we're seeing a lot of the risks that are being identified or where those key focuses are during the survey process. ESC is another piece. I mentioned closing the loop not only communicatively with our clinical staff, but during the survey process. ESC is the way we close the loop on your survey activity and your survey event. We review those in central office. That's also another portion of my day. And I can't tell you how many times we sit down and we review these things and I get 4-word sentences. We fixed it today, period. Right? I just want to get this ESC off my desk. Just tell me what you did. We turned screws, right? We bought a part, right? The quickest, simplest answer. And while that's great and the system is now fixed, did we look at why it was broken in the first place? Buildings are living, breathing, growing, changing things. Okay, it happens every day. Do I expect there to be a facility that has every single door functioning absolutely perfectly every time I'm on survey? Of course not. I know better, because those are things that get used on a daily basis by thousands of people. What I want to know is, do you have a process in place to catch that? Are you looking at them once every 6 months on those mandatory standard required environmental rounds? Or do you have a BMP, a building maintenance program in place that's going to let you catch those? Do you know what your high risk areas are versus your low risk areas, your high traffic areas versus low traffic areas? I want to focus on whether or not you have a process in place that's going to help you to get to that successful point. It's kind of given that we're going to find something because, again, it's a living, breathing, growing, changing place. You never do any construction, right? You should never have any construction project. Nobody's putting any money into construction. You're never remodeling anything. There's never a contractor on site, right? Because, those aren't entities that can cause you issues. I'd like to look at what the processes are for closing the loop. ILSM process, what's construction closeout look like, right? When we get to this ESC place, do we just simply say, yeah, we train staff to do a better job? Commingling of oxygen cylinders, for example, that's a 261 score. Yeah, you know what, we train those clinicians again and we walked away. We'll come back in 6 more months and we'll ask them the same question again. Are we just filling in that blank with it's somebody else's problem, or have we taken a step back and taken a look at that process and how we can impact that process to make the process better in the big picture? Do we have the right people at the table asking those questions? At the end of a survey, does the quality team carve up the report and say, here's the 5 EC standards, here's the 2 life safety standards, go off in a room and then come back in 3 days with answers? Or are we sitting at the table and we're figuring out, you know what, we've been trying to get this project funded to replace this equipment for 2 or 3 years now. It's really not surprising to us that we had some observations in this area because we haven't fixed this equipment yet. Those are discussions that need to start to happen, and the ESC process is a great time to be able to tie those together. Does that make sense? Everybody here everybody do an ESC before? Maybe have no idea what I'm talking about? It's okay, you can admit it. Well, evidence of standards compliance. Yes, thank you. If I use acronyms that you don't know, please feel free to tell me. I did have to get a new dictionary and learn an entire new language 5 years ago, and now it's kind of just slipped in. I do it in my sleep. I married an architect, and he has no idea what I'm talking about half the time when I spit acronyms during the dinner process. It's very strange in our household. All right, couple of standards language changes. None of what I'm about to show you should be surprising. However, I'm showing it to you because as the last year or so has gone on, I've seen a significant increase in the survey reports that I have been reviewing. And in my mind, these were simple changes that should not have had that major impact. So I want to call your attention to them just in case, because these are little things that may slip through the cracks. January of last year, so a year and 9 months ago, we redefined what quarterly meant to the process. Prior to January of last year, quarterly was one time within the calendar quarter, right? So you could do it January 1st, and then you could have done it June 30th, and you would have been in compliance because it took place once in each calendar quarter. Well, when we redefined last year, what the definition changed to is once every 3 months plus or minus 10 days. So what that means is if you did it in January, you have to do it again in April. You could do it the back 10 days of March or the front 10 days of May. That's your plus or minus. But you have to do it in April. You can't push it off now until some other time within that calendar quarter. That was a big shift for people. People didn't really wrap their brain around the idea that we were doing this now on a 3-month basis. It's not just somewhere within that calendar quarter, okay? I hate this, but some people like it, so I put it up. If you like it, great. If you don't, forget I showed it. I mentioned we were redeemed last year. We had a couple of new EPs that came into the fold. Those new EPs were a direct result of the CMS process. CMS looked at our book, and they came through and said, you know what, you're missing some things. In order for us to redeem you, you must write elements of performance for this. One of those is radiation workers being checked periodically by use of either exposure meters, badges, or tests for the amount of radiation exposure. Most places were doing this, but we didn't have a process to call you out and say, are you doing this? What does it look like? This is what's going to happen. So expect that clinicians and or life safety surveyors in this area may ask you for this documentation to ensure that you're checking your workers for their safety. This one had me stumped, but we were required to write an element of performance that says you have a procedure for the proper routine storage and prompt disposal of trash. I know that sounds crazy, right? Medical waste is regulated. We've got all these regulations, all these things that you're looking at, and they said, you know what, you're missing trash. So here's an EP for deemed status organizations. Make sure you have a process for trash. If you don't, you're probably in a much bigger problem state, I'm guessing, but there it is. Yes, sir?
You say you have to have a written process?
You just have to have a procedure. What's your can you tell me what your procedure is? Yep, he's scheduled on 3 days a week. He's scheduled, whatever. The garbage truck comes, we have a contracted service, here it's in place. You can show us that you have a given procedure that will ensure that you have the proper disposal of trash from your facility. I know, it's just, they made us do that. Yes, that's correct. EC 233 for fire drills. We needed to add language that stated that your fire drills are held at unexpected times and under varying conditions. What we found was a lot of organizations were doing first shift drill at or about 7:15. So while they were unannounced, every first shift drill in the book for the last 5 years was done at 7:15. So there was nothing unexpected about that. And there was concerns about staff response, staff engagement, and all that other good stuff. So we had to add pieces in here that required you to vary your time frame in your conditions under which you did your fire drills. Also, and this may have been where some of your question came from, our old language within the standards was not consistent with what was in NFPA. So we needed to make a change to EP4 to identify that audible alarms could be silenced during the fire drill process, not deactivation of the full building fire alarm system itself. Yes.
I'm resisting weighing in on this one.
That's okay. It's a contentious topic of late.
And we can agree to disagree. I'll just give a quick commentary on it.
Sure.
I actually sent a response up to George Mills about this. Did a bunch of research in NFPA 72. The history of the old code on NFPA 101 in relation to silent fire drills.
Yep.
There are fire alarm panels that can't be silenced.
Correct.
The intent to put back in 2000, there were panels that couldn't be silenced. The purpose of the fire alarm drill is for staff education, not for the testing of the equipment. The testing of the equipment is done by different
EP.
standards.
Yep.
And it was only recently that this has started coming up when Joint Commission started inspecting this, and it's actually most of the hospitals that I was aware of until recently were doing silent fire drills. And then when it started getting inspected, some of them, if they don't have the ability to actually silence the panels, there's other ways that they were figuring out workarounds that I think is actually more injurious to the system, because if somebody forgets to put the panel back in the proper condition,
And during the day, the alarms still don't go. Yep.
I think my concern is that Joint Commission, by inspecting this way, and maybe perhaps putting a twist on what was intended with the code for the silent, being able to do other forms of notification, is actually creating a process by which we could end up with an incident somewhat future. So that's my commentary on it.
Sure. Sure. Did everybody hear that, or should I say it a little louder? So there's been some discussion about what the intention behind the actual requirement in the life safety code is. There's some commentary that ties the purpose of the fire drills being back to test your staff and not actually the functionality of the system. NFPA 72 has requirements for testing of those different parts and pieces of the fire alarm system, both as an entity and as components, and that the whole intention of the fire drill is really not around the system and whether or not it's required to transmit the alarm, based on those purposes. And again, I understand there's a lot of people that are asking this question. Did again come out as part of our deeming and review of those elements of performance. It is not just us. There are many, many state entities that are citing for this. I would agree with you that I think there are a number of organizations, again, based off of the fact that we wrote the EP inconsistently with the specific language of the core requirement in the code. I agree that there's a lot of organizations that haven't been testing the fire alarm system as part of the fire drill process. And I'm interested to see what the shift to 2012 will do and what updating to the newer editions of the code will get us as far as a movement is concerned. Yes, ma'am.
Can you define the shifts in terms of hours, please?
Sure. I cannot do that for you because my standards are not prescriptive. I will not tell you what a shift means to you or your hospital. As far as I'm concerned, if you tell me you run 2 shifts, 7 to 7, 7 to 7, then I want 1 per shift per quarter. I will tell you that I've gotten notification that there are some state agents who are saying that we should define what shifts are. There are a couple of states, yours is not one of them that I have heard, but there are a couple of states that say they don't care if you run 2 shifts or you run 4 shifts, they want 3 shifts, morning, afternoon, and nights. So I would check back with your local entity, make sure you don't have a city requirement or a county or a state requirement that's beyond that. But as far as the standards are concerned, we leave shift definition up to you. Yeah. Anything else? Yes.
What if your shifts vary, like the engineering standard was 8 hours versus the standard was 12 hours, or separate?
Yeah, that's a great question. So what happens when you have varying shifts? Clinical does one thing, you guys do the other. I would tell you to go with the most restrictive. Just to cover the bases. If you are able to run separate drills and you can show that you're covering all of those staffs across that shifting, it's difficult. I think that's trickier to manage personally. I would in that instance suggest that you go with the larger number of shifts. If engineering is running 3 shifts, clinical is running 2, I'd run 3 drills per quarter to cover that, and that way you've got full coverage across the board. But if you can manage those 2 different shifting styles, more power to you. Okay. Anything else? All right. So we don't have any other questions on standard language. What I would like to talk about were the significant changes that we made. We're a little over a year into this now. So this is now really being surveyed and truly implemented. There's a little bit of that grace period that happens when we make major changes to the standards. We usually let the field get used to it a little bit and then pick up in scoring. Well, we are there, so they've seen quite a bit of scoring changes for this. I'd like to talk to you about the major changes to medical equipment. and utilities. Know that for those of you that have been through one or two of our survey processes, EC24, 1 and 3 for medical equipment, both the documentation side of it as well as the ITM activities themselves, that language parallels very closely to the utility system at 251 and 255. So I'm just going to talk about utilities, but know that there are very similar language changes and counterparts on the medical equipment side in the 0204 series, okay? This is applicable to all of the hospital and critical access hospital programs that are out there. We did not change EP number 1 for utilities equipment, and that is that you design and install them to meet patient care needs, operational needs. That remained the same. There was no need for change there. However, for deemed status hospitals, and everybody knows what a deemed status hospital is, right? You're getting Medicare and Medicaid funding. You're utilizing us for your CMS purposes. If you are a deemed status hospital, you are required to maintain a written inventory of all operating components on your utility systems. You can no longer risk out any of your utility system components. Most organizations were already doing this. You already had a good handle of what your utility systems were. A few organizations needed to expand because they did go through the risk process. Now, where this kind of got a little fuzzy, in my opinion, is that being engineers, we complicated it a lot more than we needed to. We tried to make it a little bit harder, I think, than it needed to be in the big picture. When we say that you have utility systems, and we're looking at your utility systems and your operating components, we are talking about the master system, the 30,000 view, if you will. It's the heating system, it's the cooling system, it's the water distribution system. That's the system itself. When we look at the components on the inventory, it's that next step down. We are not going to the subcomponents part. When these new standards broke and we said that we had an EP now where you have to identify the operating components of your utility system, I can't tell you how many people came back to me and said, well, this is nuts and bolts and wires and conduit. Whoa, 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 way too far. Okay? We're not looking to have you take it all the way, but it's an operating, it can't operate without that component. Yes, I get that, okay? But we want you to look at things that are gonna have performance-related criteria and things that are gonna have a measurable outcome. Take a look at it from that level and don't go too far down. So my best guess is that when you went back to what your utility systems inventories were, they probably already were pretty complete. Maybe you needed to expand it a little bit, but if you spent hours and hours and hours and pages and pages and pages, you may have gone too far. That's okay. You go above and beyond, we'll get you the gold star, okay? But know that you don't have to go that far down the list in the big picture. That was not what we were intending. At EP number 3, what we've done here is changed how we've classified. For the longest time, we were life support equipment and non-life support equipment. So people would come to me and they would say, hey, Ann, is a generator really life support equipment? Well, the generator itself wasn't life support equipment, but it provided the essential power to the life support equipment, so we always lumped it under life support. Now that we've changed the view and we've looked at this from high risk versus life support, and we have high risk and non-high risk, your life support items fall under that high risk, obviously, but I can have a generator, which is a high risk item if it fails, but I don't have to call it life support when it's not truly supporting life. Does that make sense? So that was where the shift here was. We require you in that expanded inventory to identify which parts and pieces on that inventory are high-risk elements. How did you do that? Most places that I talked to added a column, and they put an H and an N. Anything with an H is high risk, anything with an N is not high risk. Or they coded it within their BMS if they were using their building management system. However they're maintaining those inventories, they found a way to code it. Easiest way, when the surveyor comes out and asks you for a couple of sheets of that inventory to show them your documentation, they're gonna be looking for how you've made that designation and is it consistent across the board, okay? EP number 4, combined. Yes, sir. Sounds to me like you're trying to complicate this. Yes, sir. So I gotcha. I gotcha. So his question was, am I operating in normal mode or am I operating in disaster mode? And if we go back to my generator example, on a regular day when the generator's not running and you're on normal power, that's not a high-risk piece of equipment. But I would tell you that what we're looking at it is from a failure and from a PM standpoint. Is it a high-risk piece of equipment? If it failed, do we have high risk or really truly negative outcome to that, or is it low risk with lesser outcomes on it? So I guess to answer your question, I would want you to consider this in disaster mode. You're right, it doesn't. That's true. We tried to be non-prescriptive with that as well. I agree with that, but I will tell you, especially like from the generator standpoint, your testing and your maintenance activities are dictated for you. FPA 110 is going to give them to you. What about your battery backups? UPSs? Uninterruptible power supplies are not, they're bridging devices. So in my opinion, personally, I think they're non-high risk, but depending upon what you have them connected to, they could become high risk. It just depends. And not all UPSs are necessarily going to be, just because it's a UPS doesn't mean it has to be one or the other. Part of the criticality model and looking at your inventory is what's it connected to and what is the risk to you at the organization. I might. I'd have to look at your risk criteria also. When you get into your matrix and your model to determine what's high risk, how are your categories? Where are your risk priorities? Most places use a numbering system. Where does it fall out in the numbering system? Okay. EP number 4 combined a couple of our EPs. We used to have an EP to tell you to set frequencies, and then we also had an EP to tell you to set activities. We combined both of those together, and now we're just asking you in one place to do both frequencies and activities. We're also telling you that when you're setting those activities, you can vary from manufacturer's recommendations and follow, here's a new acronym, an AEM, an Alternative Equipment Maintenance Program. The AEM, of course, cannot reduce the safety of the equipment, and it has to be based on a standard of practice. So if you're going to do this, we can't just say, you know what, we don't like this manufacturer, we don't want to listen to him, we're going to go a different route. We want to make sure that that different route is founded based in a national practice of standard, or that you're making that decision for good, solid reasoning. Now, there are some pieces of equipment, and this also ties over to medical equipment, that cannot be put on an AEM. If you are going to use an AEM, you have to be very careful about which pieces of equipment you use an AEM on. If the equipment is subject to any federal, state, or Medicare conditions of participation that requires manufacturer's recs, you cannot put it on an AEM. Also, if you have new operating components that don't have sufficient maintenance history, you can't use an AEM on that because, again, what is the foundation and the basis? You need the maintenance history to be able to do that. But know that maintenance history are records provided by either your contractors, third-party vendor, for example, that has significant maintenance history for this particular piece of equipment. You can utilize that existing data. Any nationally recognized sources that have those data sources, and your own hospital experience over time as you begin to collect the data can be used to determine that AEM criteria. Okay?
So those would be acceptable if you cannot get a manual for purchasing a piece of equipment.
Sure. Absolutely. Again, based on the S&C letter, this is where the language change came from. It's from CMS's S&C letter on these particular pieces of equipment. Now, on the medical equipment side, it will also talk to you about imaging and radiological equipment that has to be maintained per manufacturer's recs. And also, if it's a medical laser device, you can't put that on an AEM. So talk to the biomed guys. There's a couple of things they're not allowed to touch in the big picture. EP number 6 talks about qualified individuals that are using the criteria to establish this particular information. There is a connection here at the HR standard. So if you're going to follow through with an AEM, you want to make sure that the qualified individual is doing it. Take a look at the HR standard for qualifications in their personnel file and make that connection. Excuse me. And notice that the EP simply says a qualified individual uses the criteria. What does qualified mean? And this is the connection back to your HR standard. We're not telling you what qualified means. We're not giving you those qualifications. you need to identify for us how you determine that that individual is qualified to make these decisions. Does that make sense? Excuse me. In addition to the high risk, non-high risk category, if equipment is on your inventory and it's being part of an AEM, the inventory has to identify that it's part of that AEM as well. Again, most places are just adding a column to the spreadsheet in the big picture to let us know that they varied from manufacturer's recs. EP14 was just a number change. The language was exactly the same. You still have to have a process for minimizing pathogenic biological agents for your cooling towers, domestic hot and cold water, and aerosolizing systems. EP15, language again did not change. This is my old EP6 for improper pressure differentials, just got a new number based on those brand new items we added at the front part of the standard. Next section is EC 255. Now, 251 is the administrative piece, right? I told you guys you had to have an inventory. You got to have frequencies and activities, right? That's all paperwork. 255 is what did you do in the field? It's the actual inspection, testing, and maintenance activities that you do as a result of what's called for in 251. I was really happy to see this added. Originally, we told you that before any initial use, you had to test your system. Now you also have to test it after any major repairs or upgrades. And again, that's one of those silly things because you're all sitting there saying, we always test our stuff, right? Well, I never had a tie back in the standards. We never told you had to do that. So if you didn't, there wasn't much I could do about it. Now I have language that says if you make any major repairs or upgrades, you have to show us that testing documentation to close the loop. This is the reconciliation between life support and high risk, simply switching out the language in terms. Again, making the connection. This is EP number 4 is your infection control utilities equipment. So this made the connections to the different EPs associated. And EC 255 connects non-high risk, again, as opposed to non-life support devices. Make sense? Any questions about the major changes to utilities? Anything I left off? Okay. Government restrictions. You guys don't ever have the government restricting you in any way, shape, or form, right? Everything runs really smoothly around here, right? Super easy. Nothing. I have a line item in the SOC. Who's responsible for the SOC here? A couple people. This is a copy of the sites and buildings page, the basic building information from the SOC. Should be pretty familiar to people. We do have this column right here you see circled in red that questions whether or not you have any governmental outreach, if you will, that would impact your ability to meet the standards for testing. You'll see here this organization has identified no. And the question came up, well, what do I do when something happens? Well, when you click on the building itself and you enter the main building, that will pull you into those pages of the BBI, the information you provided to us that you can update and change at any time that you would like. If the front screen says no, it means you click the radial button for no here. What the question is asking is if any local or state government restricted your utility testing. Why is that important? Well, I have a whole document review session. I have a ton of elements of performance that are all tied to systems testing, right? And if you have somebody walk in your door and say, don't you dare, we've got to have a way to be able to tie that loop back and connect that to our survey process, right? So the surveyor doesn't come in and say, hey, but you were supposed to. So if that happens, right, because you're like flush with water right now, right? You guys don't know what to do. You've got so much water, you don't know what to do with yourselves, right? Everybody's surfing. Duh, right? Anybody want to run their fire pump for a while today? Might make anybody, nobody be unhappy about that, right? Well, it's documentation, part of the survey process, right? Can't run your fire pump, for example, that would be something that you would come in here and choose the yes button. Now, if you're going to choose that yes button, the minute you hit it, this red note's going to pop up to draw your attention to it, and it's going to say that we require you to document this in your additional comments box. Give us a couple sentences. Tell us what happened, even if it's obvious to you. I live in Chicago. If I'm your surveyor, perhaps I'm in a bubble, and I don't know that you're in the middle of a drought, right? Tell me what's going on. Tell me what entity said you couldn't do what. Tell me why. Give me some pieces to close that loop so that when
Require documentation from the outside agency.
if that's possible, that would be great. Most of the time, if they're going to tell you you can't do something, they're going to issue that to you in some way, shape, or form. I'll take an email, whatever you got. We'll work with you as best we can to make those connections in the big picture. And of course, that additional comments box actually just happens to be right below. It's the next line item in the SOC, so it's pretty easy to document there in the big picture. By the way, this is yet another way for you to show the surveyor that you're keeping your SOC and your BBI as a living document. I get that question a lot. How do I show you? Because there's really no trigger. How do I show you that I looked at it? How do I show you that I updated something? We didn't want the SOC to be a big brother, so there's no fingerprint on it. I don't know who the last person is that touched it. The only thing I know from the front screen of the BBI is the last time somebody updated plan for improvement information. There's a date, and it shows me the last time a PFI was touched. Now, you could have fixed a spelling error in a plan for improvement, and that date would change. So I don't even know what you changed. I just know that you touched a plan for improvement. So when you come in here to the BBI and you make these changes, it's another way to show us that you're utilizing it as a living document and maintaining that as current and accurate as part of the statement of conditions.
If CMS doesn't recognize it, they make you guys get rid of this.
Okay, so there's no condition of participation. Wait a minute, you asked me 2 questions. Which one would you like me to answer? There is no condition of participation attached to the actual SOC itself. The only time I have a condition of participation attached is when I score issues with the categorical waiver. So if you are not utilizing a categorical waiver, or you are utilizing a categorical waiver, for example, and you haven't documented it, I would identify in the SOC that it's not current and accurate because you're required to declare. I have a condition of participation, I can connect to that. Outside of that one, I have no COPs. So they couldn't tell me or us that we couldn't have this because there's no COPs and there's no link to the CMS process. Now, the second question you asked me is, why didn't they make me get rid of the SOC? It's no secret that CMS is not a fan. They don't really like it. It is our process. We believe in it. We have fought tooth and nail over the last 18 months for the SOC and for its processes and what we do. For those of you who have been surveyed since July of last year, you know we had the major changes to the report, the OFIs, the opportunities for improvement. People were a little up in arms about the plans for improvement. Plan for improvement box in the report is simply a number. It tells us that on the day of survey, there were 27 PFIs. The day of survey, there were 3,206 PFIs. You can print it if you really want to press print and put it all in the report. The interesting thing about everybody who was up in arms is that the SOC has always been printable. We just never attached it to the report. We always locked it down as part of survey process. It was just 2 standalone documents. So all we've done now is kind of pull them together. Pulling them together seemed to meet CMS's needs for the time being. We're going to continue to fight for the SOC and continue for its use because we believe in proactive, ongoing approach and maintenance to the process. Okay?
You still mention it in the OFIs when there's a PFI, so doesn't that satisfy CMS?
For right now. Yep, I'm hoping it'll stay that way. So when you update that, you'll see here on the front page that no turned to a yes. That's a key indicator to the surveyor that they should take a look at that there's going to be some kind of document variance during the document review process. Extensions. Talking a little fast here. Extensions. We made some enhancements to the SOC, Plan for Improvement process, with the extension process. I don't know if it's a turnover in facilities. I'm not sure where the variation came. There is still some fuzziness in the field about what an accepted plan for improvement is versus a non-accepted. When does it happen? We only accept plans for improvement during survey activities. We do not, I do not sit around all day. People actually think that I spend a portion of my day pulling up HCO numbers and taking a look at your SOC. I really wish I had that kind of time. And I'll tell you, I'm not very good at guessing numbers either, because every time I try to guess a 4-digit combination, it comes up with an invalid hospital. So I'm not good at it, can't do it. But once the PFI is accepted during the survey process and it locks it down, that's when you have to formally request for an extension if you cannot meet the projected completion date. It's going to turn bright yellow. I will have a picture of that for you here. In the SOC, you're going to get this indicator to say, hey, I'm almost due. I'm actually 4 months overdue. Do something with me. Well, the new feature here you'll see on the left-hand side is to request an extension. Now, here's the difference. This is a new plan for improvement. This is an accepted plan for improvement. The accepted plan for improvement has the box. You can click on it and you can request that we do an extension. Here, there's no box. Why is there no box? Because you're supposed to do that. You retain edit rights. When the plan for improvement is new, I don't know that PFI exists. It is on you to go in there and make the necessary adjustments. I don't need to do that for you. So you can check on the box for request an extension. It will then give you a reason for the extension. When you click on that, it's going to give you a little drop-down box. Special order part will not be delivered for 4 more months. I don't know. What's the reason? Construction activities took a lot longer than anybody ever expected them to. We had an earthquake. Whatever the reason is, whatever's driving your need for extension, it would go right there in the box with your new projected completion date. What are you requesting us to extend that projected completion date to? And then it's going to give you a pending status at the bottom. You will know when we go through because it will be processed. It will send us an email to tell us that you are now looking for an extension, and we can now go through the process of filtering through those and granting your extensions in the big picture.
Taken care of relatively quick.
Mhm.
I mean, you can deny it, right? If you see something that says, "Oh, I haven't changed the doors yet,"
Yep.
I never got it done. There's no excuse for that, right?
You can almost expect me to pick up the phone and call you. Yep, absolutely. And I do get some crazy ones. I mean, I've gotten, we have penetrations. We did a whole house penetration project I would like to have till 2026, and I'm not exaggerating. 2026 to complete all of the penetrations in my building. Thinking that might be a little bit long. Even in the underfunded areas of the world, right? Equivalencies. This is kind of my baby. There is only one of me. I'm the only one that does equivalencies. And as you can tell, I'm standing here in front of you today. So if I'm standing here in front of you today, what am I not doing? That's right. Okay, so be patient with me. I'm doing the best that I can. Part of deeming in this big picture is that CMS didn't like the fact that I was sitting at a desk making an engineering judgment. And CMS said, I'm sorry, you can't do that anymore. You can review it. And as a matter of fact, I'm going to require you to work with the organization to ensure that whatever the request is approvable. And then I am now required to send that request off to CMS with a recommendation for, obviously, approval. I'm not allowed to send them anything I would deny. There are 10 regional offices. So I take your submitted information and I send it off to the regional office with a written documentation and recommendation through a SharePoint site that CMS has created. I forward your documentation on, and then I sit patiently and I wait for them to answer me. Some regional offices are quicker than others. Some are friendlier than others. It's still, even though the process started in May, it's still a work in progress in the big picture for us to work together. Let's assume I'm successful and I convince the reviewer to approve your equivalency. Just like in the old days, I will post that in the history audit trail. Now, if I'm unsuccessful, I will also post that in the history audit trail. I've so far had a few rejected. We are working through the process of trying to get them to do a second review and come up with a better reason for their rejections. But we will post that communication with you through the history audit trail process in the big picture. So,
Are they qualified individuals out there?
is CMS qualified to do it? Well, that's a great question. So each one of the regional offices hires different people of different backgrounds. I know that the regional offices have a number of fire marshals that work for them. I know that some of the regional offices have registered architects that do a lot of their work, some building officials. I don't know how many regional offices have professional engineers. A couple of them do, but not many. This is the history audit trail, which again is found under the PFI tab on the drop-down menu. Any communications we have with you are found here. So when you have a survey activity, for example, full unannounced survey happened. I heard a couple guys had to leave today because a couple of my friends showed up at the door. That will be documented here in the history audit trail for that organization, that on this day, full unannounced survey, here's the surveyor that was there. We document anything that has to do with the history audit trail tied to the either extension process or equivalency process here as well. Does anybody have any questions?
What about there's a lot of focus from Joint Commission on the EC and life safety standards.
Mhm.
And, you know, the Institute of Medicine, Office of Inspector General, Human Services, and the Journal of Patient Safety, they're now stating like 210,000 to 440,000 deaths occur per year, right? From like the permanent affliction from whatever hospitals say that it came in. Like the only fire that found where someone died was like 1961.
Right. We're down to less than 1 fire death a year.
You know, all the findings seem to be really picking on the facility guys.
Mm-hmm.
And I'm wondering, why is this occurring? And why is that not a focal point for the Joint Commission?
Sure. So hospital-acquired infections actually is a focal point for us on the clinical side. We have the Center for Transforming Healthcare, which does a lot with their targeted solutions tool and other things from a clinical perspective. One thing I will say is you are absolutely correct. We are down to less than 1 fire death a year. I think a lot of that has to do with the changes in technology, the fact that back in as recently as the 90s, hospitals weren't required to be fully sprinkler protected. It wasn't until the 90s that we got into the new language of the code to put sprinklers into hospital settings. But tied to that is the maintenance of those systems, the appropriate function of those systems, and testing of those systems. So some of that lack of fire death comes with some of the regulations and some of the things that we are doing as an industry to maintain those systems that are put in those buildings. So I'm not one to just quick jump and say, hey, you know, the code's moved on, we don't have to do any of this stuff anymore, because I think we still do need to do it. Why does it end up as a top score? I don't have to tell you, because you work in hospitals every day. Tell me a single place that isn't dealing with some sort of aging infrastructure. Show me a hospital that doesn't have some sort of aging infrastructure in place somewhere. And you guys are so good at your job. I think facilities, plan ops, none of those entities, none of those groups, safety, you don't get enough credit for the work that you do in the big picture. You are so good at maintaining systems and creating stuff that just doesn't exist, fixes that just don't exist. You create them and you make them run, and you get 1 more year out of them. And the 1 more year you get out of them is 1 more year we don't have to replace them. And so there is some focus. George and Dale Wooden over at ASHE are working on some aging infrastructure legislation. Joint Commission has a DC office. We work on Capitol Hill, and we do work with certain lobbyists and that sort of thing. And I will tell you that we are working through our DC office on aging infrastructure discussions, attempting to see if we can have some sort of legislation come together. Again, that's above where I work, but I can tell you that those activities are happening. It is in the forefront. On the clinical side, our counterparts are focused on hospital-acquired infections. We are looking to see if there are ties between HAIs and the physical environment, and if there are, can we bridge some of those gaps? Again, that may be tied to some of these aging infrastructure, some of these aging buildings that we have.
If it's the third leading cause of death,
Yep.
over, I think first cardiac, pulmonary disease, heart attack, and then next is cancer.
Sure.
I mean, it just seems like the focal point is completely wrong.
Off.
Especially, I mean, Gary brought up a real great point, and we've all seen it, every one of us in here. When the life safety guy comes on site and says, these are all the things that we need to see, and I need to see them now. Well, the nursing surveyor shows up, and she says, you know what, we want to see 10 to 15 charts, make sure they're ready for them, have them ready for me by tomorrow's session. What do you think that hospital's doing? There's a team of people working on to make sure that the most perfect one is given to that surveyor. No, that's what happens. I mean, I guarantee you that's what happens.
Okay.
That's the thing, it's missing the boat. Like, if you want to find something and stop some of these deaths,
Sure.
they need to dive deeper into that. That's all I'm saying.
Through the patient tracer process.
And I think I'd like to add that what we're not trying to do is spill beans so the Joint Commission changes the soup process.
Sure.
On the clinical side.
Sure.
But I think that the folks in the room, the healthcare facility folks, are concerned about the amount of emphasis and attention that's being put in the negative media
Sure.
that's being said. The environment, care, life safety, always in the top 10.
Yep.
And we're basically
isn't that you're killing people with it.
And on the clinical side, where, there is clinical evidence, about 460,000 deaths a year from clinical errors. And then we're working on trying to push legislation for aging infrastructures. How's that going to affect our healthcare costs, and how is that going to result in actually changing the conditions where we're killing 460,000 people from clinical errors?
Sure.
Why are those two not connected?
Not connected in the big picture. And I don't know if I have a good answer for you.
All you can help us and our Joint Commission is everybody thinks that they're exploiting the physical environment because everybody can see a dirty sprinkler
Sure.
or something in the corridor, and the people who are not well qualified are allowed to do these surveys, and that gets rolled into those numbers. Which I'm telling you that is possible. Your numbers in some of the they're going up because of these.
Where's the clinical impact to clinical observations in those top 10 and those top 8, EC life safety? And I do see that, and I can understand where you're coming from on that point. I don't know if I have a good answer for you. I can tell you that I know that our clinical group is working through hospital-acquired infections, and they're working on promoting some of those programs. I also agree with you that there needs to be that bridge. As I mentioned, communication. I mean, I can talk about the easy stuff. How do we talk to our clinical staff when you guys are doing your rounds, you're doing your training? How do we connect to that level? There are obviously many more levels that tie hospital-acquired infections into everything else in the big picture, and plans for that. I know as an entity and as an organization that our clinical counterparts are working through some of that. I think that some of the challenges with the changes to the healthcare payment system, when the Healthcare Affordability Act came through, I don't know if they knew exactly what they were taking on when they did it. And I don't know if the focus, as you've said, is in the right area right now, or if it's able to be. I am happy to take some of that back with me. I take all of that information back with me and move it forward kind of as a recap to some of this. If there are additional activities that are taking place at this time that I'm not aware of or I haven't been able to explain, I'd be happy to reach back and touch base with you and let you know that this is what they're doing and where we're going forward or what we're moving with.
I think we appreciate that. And didn't want to create a hostile environment.
Sure, not at all.
Thank you very, very much for coming.
You know why George sent you here, and he didn't come himself?
No.
Because of this.
Is that what it is? George didn't want to field the hard questions this time? You guys put those out there, didn't you, ahead of time? Okay. Any other questions that I can attempt to answer? I feel bad now. Okay. I think Joyce said we're going to do a little bit of a break before we do panel. Is that right? Somebody help me? On the other side. So I think they're scheduling a 15-minute break.